really anywhere that is coming into contact during any like sexual intercourse. So that would be genital, throat swabs, and anal swabs, specifically, especially for the HPV virus. There's different cancers that can grow in the throat associated with that as well. So that's a little bit newer thing. I think everyone's familiar with like a Pap smear to check for cervical cancer, but doing a throat swab is same test, it's just a different spot to look for it. HIV testing is something that I think is a little bit stigmatized, and people often are hesitant to get it done. No one wants to really know if they're positive, and so I feel like that one gets put off a little bit. We do recommend doing it at least once a year, and then more often if you are having any of those risky behaviors or having like encounters with people who you think might have higher risk than you. So that's all listed there. It's mostly just if you think someone is injecting anything with needles that might be infected with HIV, or if they have multiple partners and you just don't know about those partners, that's a good reason to get checked more frequently. The good news about HIV actually is that we are on the way to getting rid of the spread of HIV as long as we can get people plugged in with this pre-exposure medication. There's a combination pill that is 2 of the HIV antiviral meds, and you can take it once a day, every day, when you are in a relationship with someone who has HIV, or if you may be coming into contact with people who have HIV in the context where you could be contracting it. So this medication is pretty much safe to use for most people. It can have some kidney issues, but again, that's something to talk with your own doctor about if you're interested in getting this PrEP therapy. And it's safe with all of the hormones that we're going to talk about in a few minutes. So I think that's really a great option to at least like have in the back of your mind that if you're having exposure to HIV, you can take these medications to protect yourself, and it really, really dramatically reduces the transmission.
How many percent actually?
So it varies based on which medication. There's 2 or 3 different combination pills, but it's in like the 90 to 99% decreased transmission in typical use. So meaning someone's taking it every day as it's prescribed. Yeah.
Do you have to have a loading dose prior?
So the question is, do you have to load a dose? No. There's just 1 pill once a day, and there's no like.
But I mean, prior to having the partner, do you have to be on a month prior?
Nope. Yeah, you could take it in the morning of, or even at the time of.
Okay.
Yep. Yeah. And there was some study looking at whether you could take it after you had some sort of encounter, and it's just not as effective. Mm-hmm. But taking it beforehand and regularly is helpful. It's also safe in pregnancy for the most part. They have certain regimens that you can use then. And some of these medications can also be used to like help with transmission to a fetus. So if there's an HIV positive mother, there's ways to help with decreasing transmission of HIV to the baby. So there's this like task force to end HIV by 2030, at least the transmission. So, if we can find some wood, knock on it, hopefully that will be the case. But at any rate, there's these good medications that can help protect us if we think we're in a riskier situation. Any other questions about the PrEP therapy? I put the CDC website on there. They have a whole area of like patient information and then like all the research studies on this PrEP. So I think they've done a really good job at laying out the recommendations there. It used to be that you had to like be in the high risk situation, and now they're saying that anyone who asks for it should be able to get it. So you don't have to prove that you're in like a risky situation. You can just ask and the doctor will give it to you. The next preventative health thing is just a Pap smear. Anyone with a cervix, regardless of gender identity, does qualify for Pap smears under the normal screening guidelines. So we know that trans men are at a very high risk for getting cervical cancer because their screenings tend to fall off. People don't ask them about it as much, or they don't want to get the procedure done because the testosterone therapy causes a lot of vaginal dryness and makes it uncomfortable. So it's important to be aware that if you are a person who has a cervix in your body, Pap smears are still recommended, and there are ways to make it more comfortable. So just speaking with their doctor about it to help whether that's doing a little bit of hormone therapy beforehand to help the speculum exam not be uncomfortable, or even like a little medication to help with relaxation during the procedure. It's worth it because cervical cancer is no joke. And then the last thing on here is just to do whatever sort of contraception works for you and is appropriate for you. So we know that unwanted pregnancy is an issue in trans and everyone. So people who identify as trans men and women may not have the appropriate fertility control just because of misconceptions of how the hormones interact and impact fertility. But we know that both trans men and women are still fertile and can have unwanted conceptions. So it's important to just know that if you qualify for it, and if you ask for certain types of contraception, your doctor should help you get it. And if they have any issues with that, just go to a new doctor. There is no issue with doing hormone therapy contraception in people who are already taking hormones for a transition. So the best ones are the longer acting ones, like IUDs. So those are my favorite, but yeah. I'm gonna go ahead and switch the slide to the hormone therapy on the next page, and then we'll talk about that. All right, so there are two kind of basic pathways that people can go through for gender-affirming hormone therapy. There's the male to female transition and the female to male transition. And then there's this in-between where a person can choose to use either male or female hormones to meet the characteristics that they're looking for that make them feel more comfortable. So it doesn't necessarily need to be all male, all female. You can take whatever dose of a medication that helps you achieve the characteristics that you're hoping for. So we'll talk a little bit about that. Go ahead.
It's called microdosing, right?
Yeah. Yep, so microdosing or just dosing to like a certain feeling or characteristic. So some people would like some breast growth, and they can use estrogens to help with that. Things like that. Yeah, without getting like the full puberty experience of going to the other gender. Yeah. So the first one we'll talk about is the male to female transition. There are two medications that are involved in doing this. So spironolactone is a blood pressure medication that actually decreases the amount of testosterone in the body. So that is a go-to that helps kind of lower that production in the body. And then estradiol is the form of estrogen that we can track, so that we can do that in pills, patches, and injections. And you basically titrate it until either the person feels like they're at a good spot, or when you draw the lab, that it's in the range for the female gender. So men, like cis men who are born that way, have a very low estrogen, and you just kind of ramp it up to the physiologic female realm. Yeah.
Can I ask what your source of estradiol is? Is it equine? Is it?
I don't think it's equine. I'm not totally sure how the manufacturers make that estrogen. I know a lot of the estrogen creams are the equine estrogen. And specifically with doing these transitions, we like to do just exactly the estradiol form because you can measure it in a blood draw. But some of the other ones that are synthetics or from other sources can still be used, they just can't be monitored the same way.
The synthetics don't show up as accurately reported.
Yeah. Yeah, so estradiol is just the typical safe one that we use.
Okay.
Yep. I'm not totally sure on the science of how they make it or where they get it from. The monitoring for this, for both actually female and male transitions, would be blood work every couple months when you're starting, and then it spaces out later. Like most things, whenever we start a new therapy with a doctor, you're in there pretty frequently, and then once you're stable, you can go longer. The expectations of changes for a male to female transition are to decrease the muscle mass and change the fat distribution to a more female fat distribution. It softens the skin, it triggers breast growth, so it's basically like a new puberty. The testicular volume does decrease to an extent, and the important thing here is that the voice actually does not change. So when there's a female to male transition, testosterone does cause the voice to lower, but in a male to female transition, the voice will stay the same. So people who want to have a higher voice can have like speech, they can work with voice therapy, and they can actually have a surgery that helps with that down the road if they can't achieve what they're going for with the vocal training. And then the risks of estrogen, people may be familiar with it, that cis women who are born that way tend to have more blood clots than men. And so having estrogen in your body is a risk for blood clots. So that just kind of brings you as a trans woman to the normal risk that would be considered for the female gender in general. And then there's the breast cancer risk that comes with having breasts. There's heart attack risk, and then high triglycerides, so high cholesterol, which is all just from the hormone. Nothing is really out of the range of the normal for the gender. It's just something to be aware of, that you're taking on a new set of risks as doing this transition. And then we talked a little bit about the fertility, but basically, if you're doing a male to female transition, it's good to consider freezing sperm. It's pretty easy to do. It's not something that you can really go back and do later, because the estrogen therapy can actually damage the testicles. So it's good to have actually locked that down beforehand. And then the male transition, less medication, it's just testosterone. It's the same amount of blood work where you're just checking it every couple months. And then the effects would be more of like the male puberty. So hair growth, increased muscle mass, deepening voice, the skin gets a little oilier, and then the periods will actually stop by about 6 months. So that's usually a very important thing to people to know, like, when am I going to stop having a period? And that's one of the things that you can titrate the testosterone to affect. So if someone is still having periods, you can increase the testosterone to help suppress that. And then really the only risk with the testosterone therapy is that it makes the blood a little bit thicker, because it increases the amount of red blood cells in it. So that is, in and of itself, a risk factor for having more heart attacks and strokes. So you can see on both sides, those are increasing the risk. But overall, most people do very well and don't have too many side effects. With both of these, people can get a little bit more like rage, anger, just as they're sort of becoming in this different physiologic state. So it is, the analogy of puberty just goes through the whole thing. People tend to just feel that sort of unsettled feeling for a few months. Yeah.
What if the person already has anger issues to begin with?
Yeah, so having a little bit of anger at the baseline is normal. And honestly, I've noticed that most people's mental health gets better the longer that they are participating in the transition that they want. But we always recommend that people have some sort of counselor or person that they can touch base with regularly to help work through that, and like come up with coping skills to get through that. It's never, like, I've never seen that as a reason not to do the therapy. It's just something to be aware of, that it might just be flared up a little bit for the first couple months. It does get better for sure. I've also had people do, like, instead of every week injections, they'll do like every other week to try and like kind of space it out, or they'll like switch formulations and see if they have less side effects on it. Yeah.
In the case of when somebody's on, like, somebody that already blocks the period, would they have to get off that before they start on testosterone? So
Like-
it's just like if they're on an IUD or having the Depo shot, would they have to stop doing that stuff?
Nope. So those are totally fine, and that kind of goes back to the contraception that's safe with the testosterone therapy. Any of those like progesterone-based ones are good. You just want to make sure you're not like taking an estrogen, because that would be counterproductive. But yeah, the Depo shot and the IUDs are both safe and good. Yeah. Yeah.
So you can take the progesterone and the testosterone?
Yeah. Yep. And that's actually what I think that's a preferred method for a lot of people. So they don't have to like wait the 6 months to stop having periods. and they don't have to worry about the fertility issues. Yeah. And then the non-binary transitions is just a little statement there at the bottom that, you know, not everyone wants to do the full transition, and that's okay. I would say that most providers who do gender-affirming therapy with hormones are experienced in doing different combinations. Something I personally wouldn't do is, like, you don't do both estradiol and testosterone. You would just do little bits of whatever hormone would get you the characteristics that the person's looking for. And then this TransCare UCSF link at the bottom here is kind of the go-to website for all of the healthcare providers I've worked with that have done TransCare. It's a very in-depth website that goes through all of the different medications. It goes through all the things to expect. So I always recommend that people at least like kind of read through that website. You can click on whatever it actually interests you and is applicable, and then see their sources. But coming from the West Coast, that was a very well-respected organization. Their website is just very well-organized and helpful, I think. What questions do you guys have about any of that?
So you says that some don't want to go, if I understand it right, like don't want to go all the way, just want to go partially.
Yeah, so non-binary is the identity that is associated with that, and a lot of people just feel maybe uncomfortable in certain aspects of themselves and want to have their body manifest how they feel on the inside, and so we can do sort of smaller doses of all of this to help them get there. Yeah.
Do you have to keep taking it? I mean, would they have to for the rest of their life?
Yeah, that's a great question. So some of these changes are permanent and some will sort of reverse with time if you stop the hormone therapy. Things like the voice change would be permanent. If someone were starting testosterone therapy, that typically would happen around 6 months to a year, and then if they were to stop, their voice wouldn't get higher again, it would stay lower. But things like the fat distribution and the muscle changes would kind of go back and forth if you were to go on and off of the medication. Yeah. Yeah.
Again, is there more people who wants to make the total complete transition, or more people who don't want to go in the total 100% transition?
In my experience, I have had more people come to me wanting a full transition with medications and then with surgical options, which typically come into play after a year of hormone therapy because you want to see how much change you can get with the hormones themselves. That being said, from what I understand, a lot of people have other ways that they can also express a non-binary gender that don't involve hormones too. So that may be one reason that we don't see as many folks. And then also just the stigma in healthcare. I think a lot of people don't come in to ask for help for non-binary transitions because it's not as established as the trans male-female transitions. So that's a hard question to answer. I think so much of this is access issues and stigma that, yeah, that's why I'm here though. I want to break that down and help people if they need it. Yeah.
How would surgeries such as like hysterectomies, and I know men have their own version of hysterectomy,
Yeah.
how would that kind of thing affect a transition?
Great question. So that typically comes into play a year or more after a hormone transition, and it's an elective surgery that people can set up with just a general surgeon. If you were having ovaries removed, that would remove all of the estrogen producing tissue from your body. So for the most part, that's desirable because it helps with the transition to male, but that also does put people at a little bit increased risk of a couple other health conditions. So in that particular instance, people actually have to go on a very small dose of estrogen as well. But it actually does, in the long run, help with like the full male transition. It does.
If you're talking non-binary though, and you still want the hysterectomy,
They may just like leave an ovary or leave both ovaries behind. Yeah. Like when someone gets a hysterectomy for a medical indication currently, they typically leave the ovaries so that you still have estrogen behind. Yeah, for bone health and heart health. Yeah.
So do you do, outside of this, do you do actual surgeries also, or that's totally different?
I don't do surgeries.
Okay.
Yeah.
So that's totally different
Yeah.
issue of department or whatever.
Yeah, so we work closely with coordinating care though, so part of my job would be to help plug people in with surgeons that could help them get the correct surgeries that they're looking for. Or like with the ENT to talk about vocal cords and things like that. Yeah, family doctors kind of serve as like the central hub of like getting people where they need to be and making sure everything gets done.
So at what age can you start doing this?
Definitely provides, or depends on what provider a person sees, what age they feel comfortable starting a transition. As I mentioned earlier, some people will actually suppress puberty if a person is coming in with gender dysphoria at like age 10, and their parents are like, yeah, it's been going on forever, that sort of thing. The youngest that I started was 16, and that was after a person had been expressing gender dysphoria for quite some time, and their mom was on board, and they'd been looking around for someone who could help them. I would say that typically the age that I see people come in asking for help is closer to 18, 19, just probably because that's when they're like moving away from their parents and starting to kind of get a little bit more independent. But yeah, I think the sooner seems to be the better as far as helping with mental health and with making a very successful transition with the hormones. Yeah, go ahead.
I was going to say that I had actually at one point in time asked about getting a hysterectomy when I was younger.
Yeah.
And they told me I'm not allowed to get it until I'm 30.
Oh, wow.
Yeah, they said I'm not allowed to do that until I'm 30 because they said, what if? It's like, because what if you want children?
Yeah, that is a whole nother can of worms of, they call it reproductive justice, basically, where doctors try and like withhold treatments because of their own personal views on things like childbearing and that sort of thing. I think that that's an instance where you go back to your primary and say, I need a referral to a different surgeon. We need to talk to someone that's willing to do this. And I think in today's day and age, hopefully that would be doable. I have had, personally my patients would go to Portland if we couldn't find someone where I was practicing before, but here, you know, we have lots of options to exhaust before having to travel, luckily. Yeah.
So what would be a reason to suppress the puberty?
So suppressing puberty would be if someone is having gender dysphoria to the point where they really don't feel like the gender that they were born physically, but aren't quite at a point mentally where they're ready to choose and to identify as a certain other gender. So if someone is born genetically and physically as a female but feels that they just don't fit in that skin, but they aren't ready to say that they feel like a male, then you would consider suppressing it for a year or two, doing lots of counseling, that kind of stuff. I haven't seen it done super often, but it is.
Is it totally suppressing it or deleting it? I mean, delaying it.
Delaying. It would be delaying until the medication was stopped. It's a medication that just suppresses the growth hormones that trigger puberty. So the second you stop the medication, puberty would resume. Yeah. But it's a little risky for how it might impact future fertility and things like that. So that's why it's not as common of a practice. But it is potentially a future. Yeah.
What happens if, like, can a naturally delayed puberty affect that kind of thing? Like if a person has naturally not even had the puberty until 17 or older?
I think that would just maybe be a little bit more advantageous because you could have more of that time to do soul searching to figure out if the person wanted to take the plunge into doing a transition. But I don't think it would actually like impact how the medications work. Yeah. Yeah. I know the spectrum of puberty is like from 10 to 20 pretty much.
Yeah,
So.
I didn't hit puberty until I was 17 or 18.
Yeah. Yeah. Yeah, everyone's a little different. Yeah.
So growing up, how did you end up with this passion in your specialty?
So, I mean, I grew up here, and I mean, we all kind of know Rapid City is a little bit, or it was when I grew up anyway, no one talked about this sort of thing. And when I moved out to Oregon, it was so much more of a part of my medical training. It was a very common topic that we went through. We were trained how to do these medications, and we were taught how to be compassionate, I think, to people that have gender dysphoria, and it just changed my mind, or it didn't change my mind, but it opened my mind to how I could help coming back here, knowing that there are some clinics in town that do good gender affirming care, but it's not the most common thing that people advertise that they do. So I just wanted to be a friendly face and help out if I could. Yeah. Yeah.
That is one thing I have noticed. There isn't much support either for any of the outskirt people. Like, there is a lot of support for, I've noticed, the younger people who are either in the other genders or who are autistic.
Mm-hmm.
But there's not much support for people who have become an adult and are in that same area. Like, there's no support groups for adults with autism, or there's hardly any resources for adults on the who are transgender or anything.
Yeah.
I've noticed a lot more resources for children than for adults.
So are your
That's good to
patients,
know.
sorry, go ahead.
No, go ahead.
Are your patients mostly younger, in their 20s, or
That's,
mostly?
in Oregon, I had the whole spectrum of people. I had a patient who was in their 70s, who had been on hormones for a long, long time, and then I helped teenagers do their transitions and 20-year-olds. But I think now that it's becoming something we talk about, we'll just see people coming in of all ages who want to start this.
How many years of practice in Oregon?
3. Yep.
So a big clinic, how many other?
So I was actually in a pretty small town. There was only about 40,000 people in the town, and we just really had 2 major clinics that people could go to. And so I was at the residency clinic there in town. So we probably had 30 doctors working there. And we did most of the healthcare, and we also ran the hospital basically and the ER. Yeah. I used to deliver babies. I don't do that anymore. It's stressful.
Is it?
Yeah. Yeah. No, that is good to know. There's not very many support groups in town, though. I wonder if that'd be an area that we could definitely look at doing. I know a lot of these kind of wraparound clinics will help organize group sessions where people can just come meet up and talk about what they're going through. Back in Oregon, in the small town, a lot of my patients would be on Facebook groups and that kind of thing to get sort of that same community. This seems like a wonderful community here, the Cave Collective, for that sort of thing, too, but it's a good area for growth.
I think there's
Yeah, absolutely, yeah.
Thanks for your questions.
Yeah. Well, thank you for coming. I'll stick around for a while for anything else that people need, but yeah.
So if we have any more question, is it okay just to call you on this number?
Yeah, yep, that's my clinic number. The nurse can take messages and we can call you back. And that sort of thing. Yeah.